Hello, folks. Welcome, welcome. Thank you so much for joining us today. My name is Ashley Rojas. I'm the Executive Director of Fresno Varios Unidos. You could see more on my little screen here. We're really excited today to hear from medical experts who will discuss evidence-based research on drug use, addiction, and pregnancy. Our local legal and community advocates will offer insight into the current responses to drug use and pregnancy in the Central Valley and present some ideas for how we can approach this issue in a way that will advance maternal, fetal, and child health. So we're going to move right along. First, I would really like to ask Dr. Kofa to share our most current medical understandings of addiction and how addiction affects parents and pregnant people. Dr. Kofa is a professor of family and community medicine at UCSF at San Francisco General Hospital, core faculty for the UCSF Primary Care Addiction Fellowship, and she's going to be answering a couple of questions for us coming up here now. So Dr. Kofa, you want to unmute yourself?
Great. Thank you. Thanks for the introduction. And there's a couple things I just wanted to start to frame our conversation. One, I know how hard it is to just get out of bed and get to your computer these days. And so I want to just thank every one of you for being here. Today in particular is a really hard day for a lot of people. And just by being here, you've done something good. So thank you for doing that. The other thing I want to just note, I'm starting my timer so I don't talk too much, is that given the number of people on this call, there are definitely people on this call who have experienced addiction and are in recovery. And there are definitely people in this community that we've created here who are in active addiction and wanting to stop and haven't been able to yet. And there are certainly people too who are joining who have family and friends who are in recovery or in active addiction. And so I just want to acknowledge that when we talk about addiction, we are actually talking about each other. And I will commit to speaking respectfully about addiction because I know that that's what this is. And if I say anything that is harmful or hurtful, please, I welcome your feedback about that in the chat or the Q&A. So you asked me, what is our current understanding of what addiction is? Addiction has many definitions, but I'll tell you the one that works best for me as I care for people with addiction. It is a long-term brain disease that causes people to continue doing the very thing that they most desperately want to stop doing. And I think that's really hard to understand if you haven't lived with and in addiction. Like, why would somebody continue to do the very thing that they most desperately want to stop doing? Often when we talk about addiction, we say things like, well, I guess they're just not ready to stop yet and they just don't want it badly enough. And that has not been my experience in working with people who have addiction. It's not that they don't want it. Most of the people I work with desperately want out of the addictive process. It's a miserable place to be. It's the misery of knowing that you really want to stop doing something and then watching yourself do it. It's the misery of losing family and loved ones. It's the misery of losing a job and a future. Like, it is miserable, and yet it persists. And so, like, why is that? What is it that makes addiction happen? I want to just spend a minute talking about that. This is where the brain disease part of what I said comes in. People who have addiction literally have structural changes and biochemical changes in their brain, so that the part of the brain that responds to rewards, good feelings, is hyperactive. And the part of the brain that tells you to stop, your impulse control part of your brain, is actually underactive and underfunctional. So you have this actual brain disease that prevents people from being able to shift their behavior and stop their behavior. And the people who are most vulnerable to developing that brain disease are children and adolescents. 90% of people who develop substance use disorder or addiction start using drugs before the age of 18. Most of them, it's actually before 16, 14. It's really young. That young brain is much more vulnerable to having those physical changes happen that allow people to fall into addictive processes. So I often describe addiction as a pediatric disease. It actually starts really between like birth and 6 years old. There's usually some kind of trauma that happens, right? Maybe it's losing a parent or having a parent incarcerated or put in jail. Maybe it's witnessing violence or experiencing violence upon oneself. Some kind of trauma often sets the stage for early drug use, which happens between quite often 9 and 14 years old, right? And that vulnerable brain then develops these addictive patterns that are extremely difficult to escape. I had a patient a little while ago who was in my office and was just beating herself up over having relapsed to drug use. She returned to drug use. And she was, how did I do this? I am so stupid. I can't believe I'm here again. And I asked her, like, how old were you the first time you used? And she told me the story of how she was 11 years old. And she found some Vicodin in her parents' medicine cabinet, and it was her escape. And I said to her, you know, I'm not mad at that 11-year-old. And I don't think you're mad at that 11-year-old. That 11-year-old was doing the very best she could in a terrible situation. And our job is not to pile shame and blame on that person or on you, but instead to figure out how we move forward and take the next steps together, right? And so often, I think one of the things that characterizes addiction is that self-loathing and shame, even though it is such a blameless thing to have fallen into drug use at such a young age and then developed addiction. So the good news is that we can treat addiction, even though there are these very real brain changes, even though it feels insurmountable sometimes. We have good treatments for addiction. We have amazing medications, actually, for some types of addiction. We have great behavioral therapies. We can do things to help support people. We can help people get out of addiction. It's not an unsolvable problem. And you asked about addiction in pregnancy, what's different? And really, it's the same disease in pregnancy, right? It's the same issue that people want to stop and can't stop. It's the same brain changes. The difference is that there's a lot more shame. There's a lot more blame. Our society piles a lot of blame on people for using substances while pregnant. And that blame and shame actually often prevents people from seeking treatment. Even though we have really good treatments for addiction in pregnancy, we can help people overcome it. And in fact, in my own experience working with patients, that moment of transformation into motherhood is an extraordinary opportunity often for people to shed some of the family trauma that they have, to rebuild a new identity, and to like live into the future that they actually want for themselves. When I talk with my patients who are pregnant about our options for treating them, very often their first question to me is, okay, which treatment is best for the baby? Because that's what I want. People, almost universally, I see patients really focusing on how do I get the best for my baby in this process? And the answer is really what's best for the baby is having a healthy, present mom. Like that is the best thing we can do. If we want to protect and take care of fetuses and babies, we do it by taking care of and protecting moms. So the difference between drug use and addiction in pregnancy and drug use and addiction outside of pregnancy is really about how we treat it. So often in our society, we try to separate the mom and the baby, and we make the mom the bad guy who's harming the fetus, and we sort of gather around the fetus as society and try to protect it. But really what I invite us to think about more and more when I work on this issue is how do we bring those two together? Because really what the baby needs is the same thing as what the mom needs. And what the mom needs really is to be able to live the life she wants as the parent that she wants to be. So I'm really looking forward to hearing from my colleagues on the panel about how we move towards that future together.
Thank you so much for those comments and answering those questions, Dr. Kaffa. That absolutely resonates. And I think, you know, in the work that we do at Fresno Barrios with a program rooted in resilience, young mothers, it's absolutely true. Young mothers and mothers are so anchored and ready to really just to dig deep and make for themselves and their young ones. So thank you so much for connecting that for us and talking about the ways in which our current responses might be harming the outcomes that we're intending to get to. So we're going to hear next from Dr. Tricia Wright about how addiction and drug use intersects with pregnancy. Dr. Wright is a professor of obstetrics, gynecology, and reproductive sciences at UCSF. She focuses on substance use disorders in pregnancy, addiction medicine, and mental health in women. Dr. Wright, we've got your slide deck queued up, and we're going to get into your presentation. Thank you so much for being here.
Thank you so much for asking me to participate. As she mentioned, I'm a professor at UCSF in the Department of Obstetrics, Gynecology, and Reproductive Sciences. I'm also board certified in addiction medicine. In Hawaii, I ran a clinic taking care of pregnant women with addiction. And as Dr. Kaffa mentioned, you know, women don't choose to start using substances when they're pregnant. It's part of their life course, starting in childhood. So I've been asked to talk as an obstetrician about the whole idea of stillbirth and how it is related to a woman's substance use. We know that stillbirth is actually a fairly common thing that happens in pregnancy. It happens in about 1 in 160 births, and that's losses after 20 weeks in pregnancy. Miscarriage, which is before 20 weeks, or what we call spontaneous abortion, happens even more frequently. Almost a third of pregnancies are probably lost if we, you know, did very sensitive pregnancy tests from the, you know, very beginning. About a third of pregnancies are lost by miscarriage. And so these are common occurrences. In really looking at the causes, you know, in the majority of time, we can't figure out exactly what caused it. We know that certain maternal medical conditions, including hypertension, diabetes, and drug use, really contribute to about 20% that we can find a cause. And again, the majority of the causes aren't known. And what we know about these risk factors, that good prenatal care, just with diabetes and hypertension, really can normalize pregnancy outcomes. And the same is true with women who use substances. You know, adequate prenatal care can really ameliorate these causes. We can figure out if the infant is appropriately grown, and we can really provide the social and emotional support as well as the medical support during pregnancy. So next slide. So as I mentioned earlier, what basics should we know about pregnancy, miscarriage, and stillbirth? I mentioned, you know, miscarriage being so common. And, you know, the thing with stillbirths is we know that there are increased odds of stillbirth in women who use substances. When it's been looked at, alcohol causes about a 60% increase, not even double. Illicit drugs are associated with a 70% increase, and tobacco, most common use drug in pregnancy, is about a 6% increase. By contrast, we know that diabetes has 5 times the risk of a stillbirth, and high blood pressure about over 2.5 times the risk of having a stillbirth if a woman has high blood pressure or diabetes. That doesn't mean that every woman with diabetes is going to have a stillbirth. We know that with good prenatal care and good control of blood sugars and blood pressures, that pregnancy outcomes can be a lot better. And it's the same with women who use substances with pregnancy. And so providing that prenatal care is so important. And the policies that we have now that serve to punish women and separate women, as Dr. Kaffa mentioned, separate women from their children, really serves not to get women into prenatal care, but prevents them from getting the very care they need. We know that those who consume substances in pregnancy are more likely not to seek prenatal care, suffer from mental illness, have a lower socioeconomic status, and experience intimate partner violence and trauma. So not only during that formative years, about 60% of the women in my clinic had a history of childhood sexual assault or child abuse, and we're currently living in violent situations. So we need to really, as Dr. Kaufman said, take care of that 11-year-old, take care of the women throughout their pregnancies. Next slide. So, and what extent can any individual woman control her pregnancy outcomes? So in the 350 women that I took care of at the PATH clinic in Hawaii, we had 4 stillbirths. 3 out of 4 had a history of substance use, and 1 had no substance use. Of those 3, 2 were roommates at a residential treatment facility. So they were trying to do this right thing. They were getting help for their condition, and they both came up with a viral illness that caused the stillbirth. And 1 fetus had a lethal chromosomal abnormality. The 1 patient that wasn't using substances was extremely healthy, had no risk factors other than she was over 35. She had come to Hawaii to eat good food, swim in ocean, and have a healthy pregnancy, and she still had a stillbirth at term. It was devastating, and I want to keep emphasizing how devastating stillbirth is to these women. Especially if they have a history of trauma. All it serves to do to punish them is to re-traumatize them and really punish them for something they really have no control over. Next slide. So people have this view that methamphetamine and other illicit drugs really cause the most harm and cause pregnancy losses. We know it's a risk factor, but risk factor implies correlation. So, and correlation does not imply causation. Just because a woman uses a substance doesn't mean that substance caused the stillbirth. There are many other things in her life that also attribute and can lead to the poor fetal growth. So we know that if babies are normally grown, even if they're substance exposed, there's no increased risk of stillbirth. So we need to really be able to do prenatal care so that we can make sure that the babies are grown. So if they do have poor fetal growth, we can monitor them and deliver them in time. So next slide. And social situation and prenatal care are most important. We know that modifying the adverse environmental outcomes produces the better outcomes. Strong social support and enrollment in prenatal care modulate the detrimental effects associated with substance use. And women who are actively engaged in prenatal care, even without abstaining from substances, have improved outcomes. With our clinic, we showed outcomes equivalent to women in the general community who had prenatal care. So even if they were continuing to use their substances throughout their pregnancy, they had equivalent outcomes. So we really need to be encouraging women to get in care, not punishing them when they have a bad outcome. We don't punish a woman who has diabetes, and we shouldn't punish a woman who has diabetes when she suffers a stillbirth, nor should we punish a woman who has a substance use disorder, which is a medical condition, when she has a bad outcome. Next slide. And we know that criminalizing drug use in pregnancy really decreases healthcare access and pregnancy outcomes. Prosecuting pregnant women leads to worse pregnancy outcomes. It keeps women from obtaining prenatal care, and it keeps women from obtaining care for their addictions. As Dr. Kaffa said, we have great treatment for addiction. We need to get women into care. And we know that mandatory reporting requires worsen pregnancy outcomes also, without really improving care for infants and their children. We know that removing a child from his family may cause serious psychological damage more serious than the harm intervention was supposed to prevent. We know that foster care is an adverse childhood outcome and increases the risk to that child. And we know that even mandatory warning signs about substance use in pregnancy worsen pregnancy outcomes. There are studies that show this. So we really need to not treat women just specially during pregnancy. We need to treat them throughout their life and treat addiction as the medical condition that it is.
Thank you so much for that, Dr. Wright. That was really fantastic. And I think what I'm hearing a lot of is that you know, that shame and stigma and other sort of barriers to care or exclusions to care are the higher risk or are the more significant sort of factors that are impacting the outcomes for pregnant women who are also navigating substance use. And I think something else that we notice, or that I think I'm hearing, is that sometimes like love also just isn't enough. Like folks really need care. And as much as they might love their baby or even have a desire to be well, that sometimes the substance use disorder might be a barrier to accessing care. And so really hearing, right, like our role as providers, our role as advocates in dismantling some of those barriers. So I just really appreciate the presentation. Thank you so much, Dr. Wright, for that really fantastic information. We've got some questions in the Q&A that we're going to get to right now after our next speaker. And so coming up next is we're going to turn to Felicia Espinoza to hear about how we are currently treating people who are pregnant and navigating or experiencing substance use, and what effect does that have on our community. Felicia is the Fresno site director and senior staff attorney at Root and Rebound, who specifically focus on supporting systems impacted women and reentry. So Felicia, the floor is yours. And I think our first question is coming up here for you.
Thank you. Very grateful for this space and this conversation and all the learnings that I'm getting as well. I think one of the big things is always being open to learn and to be able to take in all the wealth that we're getting. So thank you to the doctors for sharing this space. To go to the first question in terms of how we currently treat people who are pregnant and use drugs, I think this is part of the bigger conversation that we as a society are having, because it depends who you are, right? We treat people differently based on their race and based on their socioeconomics. There's a lot of studies right now showing that based on who's reporting, if you have private insurance, you have Medi-Cal, if you're Black, Brown, and Native American, you may have drug tests, right? And drug tests have become proxy for parenting tests. And those are two different things, right? Social economics, women who are living in poverty also are being treated differently than white women. Race is an issue than white women with money who also are doing prenatal care. So right now, it always really does depend on what your race is and what your socioeconomics is. That's what is how we're treating people and how we're treating people who are currently pregnant and using drugs. Next slide. So I think of what we mostly think of when we think of pregnancy and drug use, and that we want to call CPS, and CPS is really here for the health of the family and the health of the child. No, that's not true, right? We're starting to learn that CPS is really about family regulation and punishment, but it's really about family regulation of Black and Brown and Native American families and people living in poverty, right? Families belong together. We're hearing from the doctors, we're hearing from medical experts that being with the mom, being with their family members have better outcomes for our children than actually removing them, right? Than the foster care system that has statistically been proven to have detrimental effects. We know about systemic racism. We're all having a conversation more when it comes into the criminal justice system. And the CPS system is, the way I've heard it, it's the twin, right? And I'm talking as a twin, right? We're twins, we're like this. So the CPS system is the twin of the criminal justice system, because systemic racism is part of both of those. When we're talking about changing the funding, changing where the money is really going to, the United States system spends more money on CPS than we actually do on things that help families, more than we spend on food stamps, more than we spend on child health care, more than we spend on community CBOs, right? We spend it on separating families from each other. And the war on drugs is when this all elevated, right? The war on drugs, when we started incarcerating Black, brown men, women at a much higher rate than they ever had before. That is also when we started bringing Black, brown, and Native American women into the CPS system at actually a higher statistical rate than when we were incarcerating them. So statistically, it was 20% increase nationwide when it comes to prisons in terms of incarcerating our people, but it's actually 25% when it comes to drug use and bringing them into the CPS system, which is really a surveillance system. It's not about taking care of the child. It's about shaming. It's about like what this parent did. It is not about how can we elevate this and nurture this family in terms of what they need. I highly recommend, so on here is Ground Zero Report. It has a lot of national statistics and very much focused on New York, but it's what right now you can go to if you're advocating, because then we're also going to talk about advocating in terms of statistics and storytelling and talking to directly impacted people who have gone through the system and how what they really needed, they were not being provided. So that goes to, so right, we want to help children, we want to help family, you know, should we call CPS was the question that I was asked. This is the time where, and if not who, right? So similar as to where we're talking about the, you know, revolution and making sure that we're getting what we need, when we're talking about dreaming big, that also means the CPS system, right? Going to the CPS system is not going to take care of us. You know, we need to take care of ourselves. The CPS system is drowning in legality and making sure that, you know, mandating reporting we heard about, which lends itself to separating the families in order to keep your job, in order to make sure you don't get legal liability from lawyers, media, you know, when it comes to mandating reporters, we're scared, you know, they're scared of being that big case of something that happens. So all of this leads itself to family separation if it is that you bring in, if you call the CPS system, and it's really about taking care of ourselves. You know, part of Root and Rebound, we not only support moms, but we also support the family. And there's been a lot of times when family removal also includes that a grandma who wants to take care of her grandchild is not approved by CPS to take care of her grandchild for a case for some conviction from 10, 15, 20 years ago, right? So the CPS is really about not just separating mamas, but separating children from their family members based on this list that isn't what the family needs. So this is the time to talk about abolition of the CPS. This is the time about community. This is the time to talk about funding what we really need, which is universal childcare. There's a lot of times that when it comes to CPS, it's charged as neglect, but it's really because the family cannot afford to both keep their job and pay for childcare. It's about poverty. You know, how do we get jobs and food stamps and healthcare? All of this is what we need to be pushing for at all times right now, you know, not just when we're talking about a specific child, it's about really all of us being together. So the next question, and what do I wish that we change, right? So how we treat people who are pregnant and using drugs. This goes back to the stigma. I think that, you know, what the doctors talked about, it's also checking ourselves, right? Checking any stigma and biases that we have as people, as professionals, as whatever lived experience that we bring to the plate. Start with checking ourselves, right? The other thing is that knowing now that birth outcomes are not child abuse, right? So you've learned from the doctors today about stillbirths, about miscarriages, you know, a stillbirth, or if it is that a child is born, you know, with substance, there's other ways that's not child abuse. The child could actually benefit from skin to skin contact, could benefit from breastfeeding, could benefit from other things when we naturally think of, because a child is born with a positive test, that therefore it's child abuse, and that's just not the case. So we have to check ourselves with that. We have to check our stigmas, and this is really the time in terms of how we treat people. We include moms and dads and people who are currently using drugs as part of the impacted community that are leading the solutions, right? We don't, you know, it shouldn't be CPS workers, it shouldn't be us as lawyers, you know, it should be people who are directly impacted, and all of us coming together to try to figure out what is best. And that includes grandmas, aunts, right? That includes mamas, that includes all of us, right? It's about the community care versus blame and shame, because we know that has more detrimental impact on the child and where they're going. So very much shout out to that report. Bring it in to making science. If it is that you're in the courtroom, I know there's some lawyers on here. Bring science into the courtroom. Make the judge realize that a drug test is not a pregnancy test. I mean, yeah, a pregnancy test is not, no, sorry. A drug test is not a parenting test, right? So that's where you bring in the science. Make the judge realize that just because someone may be used drugs, that doesn't mean that that's what kind of parent they're going to be. Drug tests themselves, sometimes, you know, you'll see the statistics. They don't even sometimes use drug tests that are allowed to be used in court, but we let it go in CPS, right? The CPS is a whole different ballgame that gets away with rules that is not right, and we should be calling out, right? And we say because it's not the criminal justice system, it's a civil law, it's less of a burden. No, you're separating somebody's family. You know, you're literally taking a baby away from a mama, and there is nothing that hurts somebody more and causes more trauma to the mama and to the baby if they're taking away their child. So.
Yeah, thank you so much for those comments, Felicia, and to all of our panelists, Dr. Wright, Dr. Kofa. I think we're hearing, you know, across the board from folks that there's an urgent need to both name and address the way in which systems of care are married to systems of criminalization. And if we really want folks to feel safe enough to access care and to trust in the care, that we really have to divorce ourselves from systems of criminalization. And we have to center families, we have to center humanity, we have to center community and love. I'm really excited to pivot next into our Q&A portion of our event. We're also going to invite some of our co-sponsors to unmute themselves and chime in if there are questions that you would like to answer. We're going to go first to a question that's in our Q&A here, and it's specifically for Dr. Kofa, saying people hear about the value of treatment and then sometimes think, one, that is easy to access, or two, that means the law should be used to force pregnant women to get treatment. Can you please comment on that?
Yeah, thank you. It is not easy to access treatment for anyone. And it is particularly difficult to access treatment for pregnant people, right? Most addiction programs or substance use disorder treatment programs don't offer services for pregnant people. And most people who take care of pregnancy don't offer addiction treatment services. So there is a very small number of programs that people can avail themselves of. It's a huge gap in our treatment system. I can't remember the second half of the question.
That treatment means that law should be used to force women into treatment.
Yeah, I mean, this is such a complicated topic, actually, but coercion into treatment is not the best way into treatment. I saw that there was another question about how do we talk with people in a way that's not shaming or blaming, that helps them engage in treatment. And I think that is where we need to be putting our energy, is how do we create spaces that are safe and welcoming and non-judgmental and non-traumatizing that will encourage people to enter treatment. And then how do we make great treatment available? Those are the gaps we have right now, not that we're not forcing people enough into treatment. We've talked a lot so far today about how trauma leads to addiction and makes it difficult to recover from addiction. And incarceration, forced treatment are other forms of trauma that we really want to avoid imposing because we have better ways.
Beautiful. I'd like to invite Dr. Wright, if you have any comments to that question, we'd love to hear them.
I agree. We shouldn't be coercing women into treatment. I mean, they tried that in Tennessee with disastrous results. And, you know, part of it is it not readily available for pregnant women. We also need to change our definition of treatment and change our definition of recovery so that it's by educating more providers to be able to provide this care without having it be solely a residential or, you know, certified addiction treatment, when we know that a lot of recovery happens with in a doctor's office, within a caring community, within a spiritual community, within the 12-step program. So there are many ways people can reach recovery. And so mandating any one form of treatment, we need to really just, as Dr. Kaffa said, embrace women and support them with what they need to recover from their adverse childhood events.
Beautiful. Thank you so much for that. I want to invite, oh, go ahead, Dr. Kaffa.
I was just going to piggyback and add one more thing that Dr. Wright started to highlight. I've had patients who were doing really well in treatment that wasn't residential. And then the CPS system got a hold of the case and started mandating other forms of treatment that would be less effective than the treatment that the patient was actually engaging in. That's one of the major problems with mandated treatment, is there are assumptions about what's going to be most effective that are not evidence-based and often can derail somebody from their functional treatment.
Wonderful. Really appreciate that. So we're going to go next to a question that's for Felicia. The question is, the law in California says that drug use is not sufficient grounds for child abuse claims, but what is your impression as to how that is playing out on the ground?
So mostly drug use has become a proxy for parenting, right? And you'll be able to find some other way to bring it in. So sometimes I see it because it's not necessarily the first child in the CPS system or was using at this time. Like, there's a way to be able to bring it in. It's supposed to be an and you're supposed to be able to prove some harm, but it's pretty much has become a proxy for bringing it in.
The next question we have is from Mary.
Thanks. At Drug Policy Alliance, we seek to undo the impacts of the war on drugs, and we're seeing some movement towards decriminalization of substance use, marijuana in particular, nationally. I just wanted the panelists to comment. I mean, this seems like a strange new frontier of criminalizing substance use to me. And I mean, it's hard for me to wrap my head around, because also as a public health professional, I don't see any good that this could do. But I guess if you were to talk to a district attorney who felt like this may have some positive impact on reducing substance use, you know, how could we argue against that?
Just like Dr. Kaffa said, you know, women don't start using substances during pregnancy. They start using substances when they're in adolescence, earlier. And so, you know, their argument probably is, well, it'll stop women from using substances, but that's not how addiction works. As Dr. Kaffa explained, it's a brain disease. They're trying to stop and they can't stop. And so just going on and, you know, advocating punishment just really continues the trauma and continues the idea that they're really probably going to be even less likely to stop, or more harms are going to be done. You know, just looking at the rates of stillbirth and everything else when women don't get prenatal care.
Beautiful. Do either of our other panelists have something to add?
Yes. What I want to add or tell the DA, like, that hasn't worked before, right? We've done that. We've tried criminalizing everything. And what ends up happening is who's being criminalized is Black, Brown, and, you know, and Native American people. You know, we've done that. It is counterintuitive. It causes more trauma to everybody involved. Like, that is not the answer. We should know that by now. And then also, that's where we raise up the CPS issue. Like, in terms of when, you know, as advocates, we're having these issues about criminalizing, we also want to make sure that that includes the CPS system, because it's not, it's not legally considered criminal, right? So a lot of times it gets away with a lot of things, even more so than the criminal legal system, right? So we want to make sure that we're also talking about CPS when all of us as advocates and people who are supporting our community are also, are elevating that as well.
Thank you so much for answering that question. We're going to go next to Savannah O'Neill.
Thanks, Ashley, and thanks, everyone. I was just reflecting in the presentations I heard most people talk about the importance of reducing shame and stigma to increase both the health of the fetus and the pregnant person. And in my work, I know a core part of that is acknowledging that only a small percentage of drug use is actually a substance use disorder, and ensuring we're providing non-judgmental care and out of the carceral system regardless of drug use. So my colleagues in the chat shared a new toolkit we released to support pregnant people who use drugs, navigating care while that's enmeshed with systems that Felicia and Ashley mentioned with CPS and punishment. So what do you all suggest and advocate for people really ensuring that we're mitigating those harms of the medical system being close? And also, what do you think the downsides are of framing any drug use as addiction?
I think that's such an important thing to center over and over again, that all drug use is not substance use disorder. When I teach about substance use disorder to doctors, the first reflection question I ask them is all drug use bad? Just sit and think about that and answer that question for yourself before we move forward, because it's not as cut and dry as we make it in medicine. So I think that's really, really important. And it does make it harder for people to share in a way that feels safe in the medical setting about their substance use. I think it's extra complicated in pregnancy because there is so much stigma around using any substances in pregnancy. And you're right that the more we can open up the space so people can have honest conversations about what's real, the more likely we are to be able to move forward and help people make choices about what they really want in any given moment.
Really appreciate that question. I know we've got one more of our co-sponsors, Jen Chow with the ACLU Northern California, with a question.
Thanks, Ashley. So as I think most people, most panelists, most of the participants know, the Central Valley is a very different place for folks to access resources and care than in places like the Bay Area or Los Angeles. And I'm wondering if any of the panelists or the facilitator would like to talk a little bit more about what are some of the unique challenges that folks in Fresno and in the Greater Valley experience in trying to access care for their pregnancy or for an addiction.
Some of the things that readily come to mind is what I think all of us experience living in the Central Valley, and especially people who are living in poverty, is the lack of resources that are here. So once you start adding mandating reporting, mandatory classes, mandatory drug testing, it's not that it takes 30, 40 minutes at least driving to get somewhere. Not everybody has a car. Our bus systems doesn't work the same way. So a lot of times we're supporting women who are trying to deal with these restrictions and these mandatory, requirements, that have to give up their jobs in order to be able to fulfill what the requirements are, right? And not talking about how the requirements aren't even respective to theirs, right? It might require parenting classes for abuse, and there's no showing that she's actually, put hands on her child, right? So putting that aside, even just the resources of trying to get places is different. The lack, we have less resources to go to. We have less CBOs. We have less substance use facilities. We have just less of, and child welfare still requires it, right? It still requires for you to be able to have a home, but it's not like they have the funding to give you a home, right? So you're already struggling with either being housing insecure before or being homeless, and now you have the added trauma of having a very limited time frame legally, right? A very limited time frame to get that done without any help. Right. So those are some of what readily comes to mind for me, in terms of the limited, what's different here in the Central Valley. Ashley?
So we're going to answer Lori James's question here. As a mental health professional, stigma is such a barrier for pregnant postpartum individuals struggling with addiction and underlying trauma because of their fear of CPS reporting, like we've talked about a lot. on this call. So the question gets to, however, as mandated reporters, what other alternatives do we have? Since this is such a huge gap in services in our community, what are your ideas for moving towards filling this gap? So Dr. Kofa, do you want to give that? I see a big beaming smile, which always makes me feel excited. So let's call on you for that one.
Well, that doesn't mean I have an answer. It means I feel the problem. No, I think there's a couple of things, and then I really want to hear other people's thoughts too. One, we are mandated reporters, but we are not mandated to report parental substance use or substance use in pregnancy. Those are not mandated reports. What's mandated is that we assess the parenting or the safety, but not that we make a report just based on substance use. So I think that's really important. And then the second thing is, I mean, I think about the Adult Protective Services Program. So APS really is designed around supporting, as far as I can tell anyway, people in their homes and creating safety in the home environment. CPS is not designed around that at all. CPS is designed around family separation. So what we really need is a system that is designed to support, to take all the resources we're using to create a foster care system and pour all that money into helping families get the food they need and the time they need and the other forms of support they need. That's what we need. Maybe that'll happen by reforming the CPS system. Maybe it happens by building a whole other system. I think local municipalities do have little semi-systems that can help out with things like that, but we don't have a big structure in place to replace CPS right now. We need to. That's my thoughts.
Yeah, really appreciate that. I think at Varios in our Rooted in Resilience program, we work with young mothers and or pregnant or parenting young people who are minors. And so there are added complications. And so the minors are engaged in CPS or foster care, and then their children then become immediately engaged. And there are so many nuances to this, but Felicia, did you have things that you wanted to add?
I did want to say that I think that especially people who are working in the system, who are mandated reporters, this is the time to be able to talk about your experience as a mandated reporter. This is the time to challenge the schools that you went to in terms of what they're teaching you. This is the time to elevate it, to this board of supervisors or other people who are funding it in the position that you're in, and how you feel like you are bound to have to do something. Like, this is the time to use your experience, because you are like, mandatory reporting lends itself to you're going to report, even though what Dr. Kaffa is saying is you don't legally have to. You're going to report, right? Your job's at stake, all of these other things. Talk about your experience on what you're going through, so people really understand what it's like and why it's harmful having these legal restrictions. So just wanted to say that. Dr.
Wright, did you have something you wanted to add?
Oh, I just wanted to briefly say that, yes, as we're not mandated reporters for drug use, CAPTA just says we need to have a plan of safe care. And so if we can, as a community, ensure a plan of safe care, that does not include reporting to CPS.
We're going to get Savannah back on the line here. Go ahead, Savannah.
Thanks so much, Ashley. Yeah, I just wanted to jump in on the mandated reporting question really briefly, since prior to my time at National Harm Reduction Coalition, I was a social worker for 12 years with people who use drugs. And what I saw through my education and in practice was different interpretations of what people actually needed to report, right? And that's based on racism and classism and all of those things, and that those things actually inform what social workers report. And so actually, how do we do the reflection to challenge your own biases that are coming up in how and when you report? So just really looking at how you're reading code and what that means. And a lot of those things are just passed down generationally through programs, through institutions, and we act as though those are the final law, and they're often not. So just wanted to lift that up in my own experience as a reporter.
Thank you so much for lifting that up, Savannah. Super important. And that the variability of our systems, right? That huge human variable, that we are people with values and beliefs and informed by larger values and belief systems rooted in all the things that we know harm us. So that is that ultimate barrier there. So we're going to go next to a question here regarding many county MCH programs are very ingrained with their county CPS program. In the assessment forms they use, a drug use question is asked. And if mom answers yes, it's an automatic referral to CPS. These are universal policies and protocols. How can we change this? Organize. These are opportunities to become orders, and to how this impact has reverberated into their lives and impacted their families and children. And so those are organizing opportunities.
I'm going to echo what you said, use your levers of power. Like, who do you know, who's writing the policies, put together a committee and change them.
Wonderful. Really appreciate that. So we're going to go to our next question here from Martina, asking, can you speak about what interventions, if any, have been associated with improved outcomes? What aspects of prenatal care are the most important? Is there evidence that antenatal testing is helpful?
We know that just the active prenatal care, so at least 5 prenatal visits, appropriately dating the pregnancy, because a lot of preterm labor stems from being diagnosed as being early because the pregnancy was not adequately dated, changing modifiable risk factors as much as possible. There's no evidence for antenatal testing in an appropriately grown fetus. So, getting growth ultrasounds, if they're available, is important, or at least following growth. And then just, supporting the social needs of the women. We would meet with women every other week for their social needs. And I think that had a lot more to do with good outcomes than the medical care that we provided.
Thank you so much. Dr. Kofa, anything you wanted to add there? Nope. Okay. We've got another question here. To the local Central Valley folks, what can people on the call do to support your work and to get Chelsea Becker and Adora Perez released?
I think, echoing what I said before, like right now, there's a lot of conversations in terms of funding of police. Let's also make sure that when we're saying to redirect money to social services, we're aware of this, right? We're aware of how the CPS system really dismantles family. When we're talking about changing funding, we're talking about funding directly to the community, right? Directly into families, directly to jobs and healthcare. And we're not just talking about changing one system that isn't helping us to another, right? So I think locally we have to make sure that that's still part of the conversation, because it is happening in the Central Valley. We're having those conversations and very much saying like the funding isn't what we're asking for, but make sure that this is part of the conversation as well. And we're not just stigmatizing and further adding the blame to our families who are trying to survive.
Wonderful. And I'll invite Jen Chow from ACLU, who's supporting these cases. Do you have any comments or anything you'd like to add, Jen?
Yeah, I completely +1 everything that Felicia says. I think there are definitely some systemic changes that need to happen in the Valley, and I think it's really important for all of us to continue to educate our neighbors, to educate our leaders about how all these systems are interconnected, and how drug use and pregnancy really, what is the actual data and science and medicine show for these particular questions. And for Chelsea Becker's case, one of the things we're asking community members to do is to reach out to the Kings County District Attorney and tell him that Chelsea Becker should be free. And I can share that contact information and more information about that campaign, which is being led by the National Advocates for Pregnant Women, who are currently representing Chelsea Becker. And we are currently also at the ACLU working to support the release of Adora Perez, another woman who has been charged by the Kings County DA and actually is currently serving time for the exact same crime as Chelsea Becker for criminalizing her pregnancy outcome. And so more information to come on how folks can support with that soon. So yeah, thank you for that question.
Yeah, and I think I would add is right. The Valley is often overlooked and as an important organizing ground. And I would say if you have resources to support folks that are leading organizing efforts here across issues, we really need that support. Elevate our campaigns, help get media attention. There's a narrative that there, are a vocal minority here who are sort of shaking the cage, and that it isn't something everybody wants in regards to change or reclaiming resources for community. But we know that we are not the vocal minority, and we know that we have the evidence to support our arguments. And so what we're asking for folks is to help lift up the work, help highlight the Central Valley, help hold our folks accountable, because they've gone long without accountability. And so if you're outside of the Bay Area, leverage your resource, or if you're out of the Central Valley, leverage your resources and lift up the work that is happening here, lift up the issues that are happening here, because they are important, they're critical to our state and to women across the country. We need folks to be paying attention to the battles that are being won and lost here without resource or support. So please be a part of that wave of change that we need here in the Valley. We're going to go to another question, and I can see that there's some information here dropped in the chat. So please copy, grab, paste, call, email. This is how we make that change happen. We're going to go to our next question here. What impact do brain changes have on somebody's ability of choice, right? To choose to enter care, to choose, etc. What does choice look like when substance use alters the brain?
I'll start with this. I think that it's, I always get nervous when we start talking about the brain changes, even though I'm the one that brought it up, because we can fall into this trap of thinking, well, then this person is incapable of making changes or parenting or making good choices. And it's not that. What it is that it takes extra support, and it takes a community to get the support that people need to be able to make the changes and choices they want to make. And so I think we need to always pair any conversation about brain changes with a conversation about, if trauma changes your brain, so can a healing community, right? And if drugs change your brain, so can some time without. So we have the ability to come into autonomous choice making again, and freedom again, and the ability to parent the way you want to. And I think I want to come back to the brain changes that I'm talking about are not just from occasional drug use, they're from really the addictive disease process. And so it doesn't mean that everybody who's using drugs has had those brain changes.
We're going to get another question from the queue. So the prosecutor in Chelsea Becker's case has argued she should be kept in jail by getting pregnant again if she got released. Could any of our speakers comment on that?
Okay, that is a problem. Gotta go, DA.
Talking about policing women's bodies.
Exactly.
And yeah.
It's like a bizarre form of forced sterilization.
Yeah. Yeah. I feel like we're in The Handmaid's Tale.
Absolutely. It's terrifying, but that's certainly what it does feel like. So we're going to get another question here from one of our participants. How do we educate providers about the efficacy of harm reduction in birth outcomes? How can we center harm reduction as an effective intervention regarding substance use disorders as a whole?
When I started the clinic, I looked at it from a harm reduction approach and looked at the pregnancy outcomes and found them very equivalent to women in the general community. So I think that shows some of the benefits of a harm reduction approach. I think a lot of work on harm reduction in pregnancy comes from the people in British Columbia and some of the great work they do with Shiwei and all of the others. So I think we can look to them when we're looking at a harm reduction approach. And shout out to Kim Sue, who is in the chat box, and her harm reduction approach for suggestions.
Savannah, anything you want to add there?
No, I think I would just echo, like, looking to the work that's been done and uplifting it in your work, and both thinking about like how we continue to challenge ourselves to get to what harm reduction really means in a core way and not just the interventions.
Beautiful. Thank you so much for that. So this is a question for our physicians. Can you comment on the positives and negatives of methadone or buprenorphine as or during pregnancy?
Buprenorphine and methadone are highly, highly effective for treating opioid use disorder in pregnancy. They're first-line therapy. We strongly recommend them. They save lives. They keep families together. They're great medications.
We need to really encourage women to stay on them and really encourage them by saying that neonatal withdrawal is temporary and treatable, and that they shouldn't feel guilty for staying on a medication that keeps them well, just like we keep women with diabetes on their insulin during pregnancy.
Thank you. We've got another question here. Let's see. This is from Megan Edwards. What about those who are not part of the poverty level, but that still cannot overcome their addiction? There is a huge classification of people who can't afford treatment, who can afford treatment and can afford all the care that others can't, but still have a problem with substance use. The focus ultimately should not be on just those in the poverty class. So does anybody have comments to that?
So right now, thank you. She's basically saying that everybody uses substances, including people who can afford. The difference is that people who are living in low income, Black and Brown and Indigenous people are being policed for it. So, I mean, the way that people can afford to get treatment, people can afford to have other family members take care of their child while they're using all of these other things, childcare, because that's happening. Everybody, uses, right? But it's only certain people who are being criminalized, who are in the CPS system, who are being treated differently. It's not attention that they want. I don't know, it's not the opposite. Yeah.
Yeah, thank you. So we are going to wrap it up. And so we're going to give a moment for each of our panelists to sort of give their final thoughts, any last words, key takeaways.
I'll do one last shout out for healthcare, not handcuffs.
There we go.
Agree. We need to treat and provide medical care and social support for pregnant women, not arrest them for the sole reason of being pregnant.
Agreed, and just many thanks to everybody who organized this and who came and participated.
Yep, we appreciate you all. Thank you so much. Healthcare, not handcuffs, care, not criminalization. We have to keep families together, and we have to keep holding ourselves and our other service providers accountable for reimagining and redesigning our system so we can reclaim our humanity, our families, and our communities. So thank you all so much for being here. We really appreciate you all. It's really fantastic spending time with you. We hope this is the first of many more conversations for all of us, but especially here in the Central Valley. Felicia Espinoza lives here in Fresno. Fresno Varios Unidos is here in Fresno. So this is our home. This is our community. The Valley is where it's at. As they say, the Central Valley, heart of Cali. So keep lifting us up, keep paying attention, and we're all in this together. So thank you so much, and we hope you'll have a great rest of your day.